Hello.
Hello.
In the symposium of microvention, so I would like to continue with the Scepter Mini. And it's not in my habits to make an advertisement to a product or whatever. But once I'm convinced that it fits in the evolution, I make it. And so here for the Scepter Mini, you will never see me making an advertisement for the web or whatever, because so this is a personal feeling. So it doesn't mean that the things are not going as people want, but for me, so I have to be convinced. And with the Scepter Mini, I am convinced that we have an income in the treatment of the fistulas and the brain AVM. Let's start. The Scepter Mini is a low-profile double human balloon, similar to the Scepter C and XC, developed for the distal vessels. We use always for it as a 1 cc syringe in order to fill it with the contrast medium, and we use only pure contrast medium and not mixed with water. So here are the dimensions of the balloon, but as you know, so we have to inflate it always under a roadmap just to see exactly how it inflates. So here are the characteristics of the balloon, which is really very, very important to know, is the fact that we navigated over a Traxxas Mini balloon, which guide wire, excuse me, so which is a 0010 micro wire. So it goes from proximal to distal and from 0.010 to 0.07. So the nose of the balloon is really very short. It means that we have only two markers differently than the Scepter XC. And so this is the MSO compatible. This is what we are speaking about. So this is the diameter of the nose of the balloon. So you can see the nose. This is the distal part of the balloon here, which is noted by C. And which is really very important to inject inside the liquid agent. Here, if we compare it with the Scepter XC, you can see that the nose of the Scepter XC is double of the one of the Scepter Mini. And so the Scepter XC has three markers. So the distal marker is one of the nose of the balloon. And for the Scepter Mini, we have only two markers which delimit the proximal and the distal extremity of the balloon. So this is what we are speaking about. So the volume, you can see that the inflation of the balloon is less for the Scepter Mini than the Scepter XC. So now let's go just a bit to the compliance and the flexibility of the balloon. So this is just a superficial malformation where we navigated the balloon. So you can see on the right image how the balloon is a sausage inside the vessel. But if you look to this image on the lateral view, you can see how in the mid image, how the balloon is compliant on the wall of the vessel. It looks like a S or whatever. So this is just the compliance of the balloon. This is a balloon which is really very, very compliant. So Scepter Mini better than a pressure cooker technique. Why? So let's say this case, so you have an iris and you have normal arteries arising from the feeder to the AVM. And so you want to make a pressure cooker, you put coils, and like this, you are obliged to occlude this artery, even if you are trying to preserve a functional area. Here with the Scepter Mini, even if you have a functional artery, so you can inflate it and inject the liquid inside the nidus and preserve this artery patent. Here is an example. This is a 37 years old male. He had got a headache and a right hemiparesis. You can see the hematoma on the CT scan. So you make him an angio and you see the small AVM, which is drained cortically. So this is a parietal AVM drained cortically in the sagittal sinus. Now, so you can see the navigation, the distal navigation of the Scepter Mini. You can believe me that the Scepter Mini navigates better than a balloon, a detachable microcatheter. But look to the balloon here. So when we navigate it in the brain, so just one trick is to inflate the balloon on the skull base, just to be sure that you can see it completely, because sometimes you don't know, so you can be confused between contrast and water, or you have a bubble inside. So which is really very important before starting navigating in the brain, so just to inflate the balloon on the skull base in order to be sure that the balloon is visible, totally visible. And once you arrive upside, you can see, so the navigation is wonderful, so you can see how distal we are, and you can see the markers, both markers of the balloon. So now in this case, you can see here, so we are in the central area, and this is the central artery that we have to preserve. You can see here, we have a normal artery coming behind the AVM. And so this normal artery is a central artery. And so occluding it, it will not be so easy. Here we were thinking about going by the vein and whatever. And so we said to ourselves that by the vein as well, we have a risk to go in the artery and create a arterial ischemia. So here is the zoom of the image. And so what we have to do is to get the balloon inside the feeder, the short feeder to the AVM, and protect this vessel. And here is the balloon inflated inside this feeder, and you don't see anymore the normal vessel, which is preserved by the inflation of the balloon. I will show you the result at the end of the procedure. So here we had to do this, just do this, and here is a demonstration of the AVM treated with the balloon, through the balloon. You can see upside the liquid agent inside the vein, leaking inside the vein. So we are feeling progressively the small AVM. And so, as you know, once we want to occlude the AVM, we have to occlude artery, nidus, and vein. And here you can see the vein completely occluded by the liquid agent. And so let's go now and see how is the situation before and after the procedure. So after the procedure, balloon inflated and balloon deflated. Here you can see the balloon inflated on the left image, balloon deflated on the right image. But if you look to the angiogram, so here is the traction on the balloon. You can see how it's easy to bring it from the distal part. So and here, so you can see the control after the procedure. And look at this. So the AVM is excluded, but if you look to the image, you can see that the artery, which we had to preserve, is still patent. So you have still the artery, the central artery that we had to preserve, which is still patent. You see how it was short to preserve it. And so here, if you want to make a pressure cooker, so with your coils, you will occlude this vessel. So in those indications, the balloon is really very important to use, and it preserves the vessels from occlusion. So for arterial approach, for arterial control during the venous approach, so this paper we published recently regarding the interest of using a balloon by the artery when we are approaching an AVM by the vein. So this is the image that I showed you this morning during the presentation. So create the aspiration when we are injecting the liquid agent by the vein. Once we want to get the liquid coming backward inside the artery and occlude the nidus and the artery backward under control. So this is a demonstration. So a female, 44 years old, presenting with a headache. She has a AVM which is unruptured. So this is the AVM which is unruptured. So I hope that in trained centers, a small AVM like this one, even if it's unruptured, they will be able to treat it in a one session and with a very low risk, because when we are Spessler 1 or 2, so we don't have the right to get a complication over AVM. So here we use what we call the multi-plug technique. So that we describe with Saru described this multi-plug technique. We described with Daniel Abud, the double catheterization technique, whatever. So which is really very important is to get the control on the arteries and on the veins when we are treating. So here we have the catheters which were in the anterior circulation. So here detachable microcatheters, and by the posterior circulation we had the balloon to control the flow. And here we came by the vein, so two collectors, and afterwards, so the reflux in the veins. So the aim is we made a transarterial embolization by the anterior circulation, and by the posterior circulation, we used the balloon. You can see the balloon on the image inflated. And so you can see how flexible it is. You can see how distal it is to put the balloon in the PCA. So you can see the septum mini, it's indicated on the image here. The occlusion, you can see how the septum mini creates the aspiration on it once we place it distally, so like in this case. And this is the control after the procedure. You can see that all vessels are filled, even if we didn't inject by the septum mini here. And so this is the result after the procedure, which is really very, very interesting to use the balloons distally like we can make it with the septum mini. Septum mini for proximal arterial embolization of for the AVF. So let's see this example. So you have what we call a duroarachnoidal fistula. So a duroarachnoidal fistula, which is on the false cerebri, supplied by the left middle meningeal artery. But you can see how tortuous on the AP view is the artery. And so this is not really very easy to cross them and go distally with a microcatheter. And so if you look to the contralateral side, you have the same thing fed by the contralateral side. The idea is to put the septum mini on both sides, create an occlusion. And so like this, the artery will become a prolongation of your catheters, and the liquid will be polymerized on the step of the vein. So as you can see it here, if we look to the artery, so the arteries are fed partially by the liquid agent. Why? Because the precipitation started at the level of the cortical vein. So here you can see that when we want to make such kind of procedure, the balloon should be distal to the skull base. You can see here on the right side the markers of the balloon, which are done here. So you can see here how low is the contrast inside the artery, because the polymerization started at the level of the vein. So in conclusion, so the balloon is very compliant and very flexible. The distal occlusion, so better than a pressure cooker for arterial embolization in AVM and DAVF. The flow control for venous approach, it's really a very nice tool. But so we don't have, so we need to master a bit the use of this balloon. Why? Because sometimes it could be dangerous to use it without seeing it very properly. So as I told you previously, so we have to see it at the skull base. And once we inflate it inside the vessel, always under a roadmap. And so once it starts to get the aspect of a sausage, so we have to stop inflating the balloon and get the control for the AVM. So I thank you very much for your attention.
Thank you, Charbel.